Well, good evening. Thank you for staying here so late. I don't want you to get a DVT or a pulmonary embolism, so bend your knees a little bit, bend your ankles, just be sure that you are fine. Thank you very much, Dr. Driscoll, for this gracious introduction. I am a charter member of this organization. I was here 30 years ago when it started. I would like to see a show of hands of the people who were here with me 30 years ago. 6. Wonderful. So it's been tremendous to see really to what this organization developed, and it's really gives credit to the people who stood behind, and I'm sure that I could read a long list of people during the 30 years who worked for this support group. It was Dr. Stickler and obviously Dr. Dr. Driscoll very soon who started this from the medical side, and I was interested in Klippel-Trenaunay syndrome because, as you heard in Europe, I trained before I came here, and I spent some time with Dr. Serval in Paris, who wrote a lot about Klippel-Trenaunay syndrome, and actually kind of instilled the interest in me, and I had a chance during the year I spent as his fellow in Paris see a lot of patients with vascular malformation, specifically with Klippel-Trenaunay syndrome. So I think by now you all know that we are talking about vascular malformations, and we are definitely not talking about tumors, and that is very important. That's one of the take-home message. And there are a couple of other important data here on this slide that you can learn from this article that Dr. Mulligan published so long ago, and that really helped us progress so much in this field, because we knew and we learned at that time in the early 80s that we should treat these problems different than the way we treat juvenile angiomas or any other type of vascular tumors. So anything that you want to learn, you can learn it from this book of Dr. Mulligan, Dr. Burroughs, and Dr. Fishman. This is a pretty heavy book. You can fight with it. So when we put together our book, we decided to make it at least as heavy as this book. This is the 4th edition of the Handbook of Venous and Lymphatic Disorders that's going to come out a little bit later this year. But what it also shows you, it is very important that you have a partner in academic medicine too, and we have considered really the Boston Children's Hospital as our partners from the very beginning in this field of malformations. You also know pretty much that vascular malformations are divided depending on which vessel is involved, whether it's on the arterial side or whether it's on the venous side or the lymphatic side, and then there are obviously those that are mixed. And you learned it that there are lesions that are high flow lesions, and those have to be treated with much more care, and those have a much different prognosis than those who have just relatively low flow, venous flow. Those, again, are, for us, fortunately, a little bit of better prognosis. So these are the main group of malformations. And Klippel-Trenaunay syndrome obviously belongs to the low flow malformations. And again, they have a much better prognosis. And one of you asked if Dr. Fishman treated the older patients. We have treated patients who were 70, 80, or 90, and you're not going to die from this disease unless, for whatever reason, you get a major pulmonary embolism. And Dr. Olmar talked about that, how we are becoming more and more aggressive in the treatment and prevention of that. When you have malformation of veins, you can have malformations of the main venous trunks. Like in this one, you have got an abnormal iliac vein or an atresia, of the vein that has never developed or just is very small. You have got atypical veins like the lateral veins. You have got aneurysmal veins, popliteal vein aneurysm. And then you can have malformations in the smaller veins. And this is a malformation in the smaller veins where very frequently actually the main trunks can be normal, but the branches and the subcutaneous veins are part of the malformations. And so depending on what is involved, that's how these patients present. You can have a spongy, easily compressible venous mass, like we call it sometimes cavernous venous malformations. You can have just bulging, painful, or sometimes not very painful varicose veins, and they are frequently in patients with KTR on an unusual side, because most of the adult varicosities are on the medial side of the leg, but the congenital varicosities are on the lateral side of the leg, and then you can have a combination of symptoms that we talked about here, and unfortunately you can have clots and then the consequences of clots, which are the pulmonary emboli. But fortunately these are not very frequent. We look at the length of the limbs, because these are, frequently can be different from the non-affected side. We look at the presence of other malformation, capillary malformations. These are the so-called birthmark or Port-Fine stain. If you have a severe venous blockage, you can have skin changes or even skin ulcerations. And usually, if you have a high flow lesion, then you have a pulsatile leg, you've got a braille, you've got a bruit that you can appreciate. So a physical exam frequently can separate the high flow malformations from the low flow malformations. And we just do a very thorough history and physical. We do a very thorough duplex exam first before we do a little bit more invasive, but still minimal invasive imaging studies. And I'm not going to go through all of those because we talked about it. But we measure the leg length. We want to know if the leg is shorter or longer. We look at X-ray films to see if there is any bony abnormality, maybe osteoporosis or practically the bone density change, or the presence of phleboliths, which are practically stony lesions within the venous malformations. We obviously do magnetic resonance imaging if we want to be a little bit more aggressive, or if we just want to know more, although in the very early age group we don't push Dr. Driscoll too much because we have to put the patient to sleep for that, and there should be a reason even just to do anesthesia, but it frequently reveals what is under the tip of the iceberg, what are the deeper malformations. And then with the magnetic resonance venogram, we see the underlying key structures that may need treatment. And these are these big abnormal veins. Sometimes we see also even compression of the veins that we may want to treat if the patient has appropriate symptoms and extensive abnormal veins. We seldom do a contrast venogram unless we do it before a planned intervention, but again, this is very important that it shows us the anatomy and it shows us the presence of the deep veins. And again, that's when we started here, we thought we shouldn't touch any of these lesions. Now we are much more aggressive, and we believe that very few patients have such a hypoplasia or absence of the deep veins that we cannot treat the painful or bulging superficial veins. This shows actually an almost normal deep system next to a very prominent large lateral veins. Arteriography we seldom do, but again, remember that there are no absolute rules. And we all see the patients with a spectrum of problems, and they can have micro shunts, or they even occasionally can have macro shunts. So each patient is different. Each of you here has a different malformation. This part we call Klippel-Trenaunay, that part we shouldn't call Klippel-Trenaunay. But it's so easy to say it's KT. So coming back to the vascular malformation, when we talk about KT, what is really KT and what do we call KT, and should we continue to call KT? And you know, there is a camp. I mean, they are fighting with gloves on to see, I mean, should it be a KT or should it not be a KT, or should it be a capillary venous lymphatic malformation? And to me, KT is something that's so difficult to get rid of. Like, would you get rid of Marfan syndrome and call it something else? Marfan. Yeah. No. I mean, Dr. Driscoll is a cardiologist, and the name Marfan is so much connected to a syndrome. So, to me, we can call the vascular malformation with the name what it is. It's a capillary venous lymphatic malformation. But to me, the KT, it's a combination of mixed malformation with bone abnormalities and then a complex vascular malformation. So, as you obviously know, venous capillary lymphatic malformation, if we talk about the full picture, and the fact is that we don't always know that these patients have all the three. You know, we don't know whether they have a full, they have a lymphatic malformation. We have to do sophisticated studies, or at least lymphocytogram, to see if there is, and we don't do it in many of these patients. So we presume that they may have all of the three, but there are, no question, incomplete forms of KT syndrome. And then, you know, there are a lot of other named syndromes, and some of them we successfully keep, some of them we try to, forget. But the names you see on the right side are names that actually are quite frequently, if not always, used in the literature. Parks-Weber is clearly differentiated because Parks-Weber is a high flow malformation compared to Klippel-Trenaunay that is a low flow malformation. Actually, the KT syndrome was described before Maurice Klippel and Paul Trenaunay described KT in 1900 in France, but the original description was quite obvious, and amazingly it held up for a long time. The title summarized the three main critical findings, and these are the nevus, which is the capillary malformation or porcine stains. These are the varicosities, and the hypertrophy of the leg. So this is the classic clinical trial. Now, they did not recognize the importance of the lymphatic malformation, but they talked about hypertrophy of the soft tissue. And we know that lymphatic malformation is very frequent, and it is a part of it. This just shows you the books of Serval, who was my professor in the mid-70s in Paris. That was a wonderful year in Paris, for a lot of reasons. Again, I just listed again the main abnormalities and clinical findings that we have been talking about during this conference. Some of the patients have the presentation of a true lymphedema type picture with a buffalo hump of the leg, but indeed they have this patient had a longer extremity. And patients with a primary congenital lymphedema does not have a longer leg. If the patient has a longer leg and lymphedema, that has to be a more complex vascular malformation. We published here with Dr. Driscoll when he joined our group, and he was the main author in this paper that gave us a little bit of idea about the underlying complications of patients that we at that time called Klippel-Trenaunay syndrome. First, it was obvious that there was something already present at birth in almost all the patients, that there was no predilection of gender. There was about 50-50. That most of them, as you could see, were young people, but even here in this series, we have somebody who was 84 years old. And then these were the clinical presentations. And again, they have deep vein thrombosis, but they only had 4% in this group. They had pulmonary embolism, but that too was 4%. So the main symptoms were pain, swelling, and bleeding from the lesions and superficial phlebitis. Now, one thing, though, I have to admit, and I'm sure that the panel agrees, that in some of these patients who have these large veins, you can have a PE from a superficial thrombophlebitis. And that makes it a little bit different from the general pathology of pulmonary embolism, because in general it's a very rare finding that you have it from a superficial thrombophlebitis. But in KP, more people, so they are much more aggressive, right? They treat more patients with extensive superficial thrombophlebitis treated than those patients. Again, it's just one of the pictures that Dr. Burrows showed that shows the very extensive malformation. And then, interesting, the embryonic vein here is medially at the level of the saphenous vein, which looks so different than the contralateral saphenous vein. Some of the patients have aneurysmal changes. This patient had a large large medial vein and a venous aneurysm that ultimately operated. But again, as I mentioned, they can have orbital aneurysm, large sciatic veins as the abnormality. In general, I have to agree that we were very conservative. And we are a little bit more aggressive, not as aggressive as Dr. Alan. He is very aggressive. But he knows what he's talking about, and that's a huge difference compared to a lot of patients that we see who don't directly come from Boston to Rochester for a second opinion or even for. By the way, we have so many second opinions that we really should apply for an extra, maybe business class seat from Delta. We deserve it, right? I mean, you see so many patients who travel from Boston to Rochester, to Boston, that increase the air traffic, passenger numbers of Delta. All right. So anyhow, what I'm saying here is that we really seldom operated for prevention. We operate for symptoms. And the reason we have done it, and we probably were and are too conservative, but I feel good about that, because many of these procedures, as you heard from Dr. Fishman, who worded it the best, we cannot make you perfect. We want to make you better than what you are, and we don't want to hurt you. And some of the procedures have side effects. Many of the procedures can have side effects, and you need real expert management to minimize the side effects. That's why it is so difficult to offer a preventive procedure to a patient who comes to us and says, I have no symptoms. How do I know that patient is going to be part of the 4% who's going to have a PD? That's the crux. That's why it is so difficult, and you really need to see a lot of patients, and we fortunately see a lot of patients and can make decisions. But again, this is a consensus of the center of experts rather than, as you heard, evidence of hard data. Because you are so special, You cannot really have, if there are another 1,000 people, there are maybe 50 to 100, and nobody is the same. We use, and I'm just going to address the surgical procedures, since obviously that's primarily my expertise, although we have switched during the years and we use more and more minimally invasive, primarily endovenous terminal ablation techniques. But we have an excellent interventional radiology team with Dr. Gloviczki's leadership, and they are very comfortable with that type of arrangement of trusting our patients for sclerotherapy or embolization into their hands. But we use a tourniquet to minimize blood loss during the operation, and we try to minimize the incision if possible to give a good cosmetic result of the operation. We used to do more stripping type procedures, which is kind of pulling out the veins. We have really changed the technique to more excision and ligation type. We use FDA-approved 206. the embryonic vein and the perforating vein, and some additional procedures too. Occasionally we do deep vein reconstruction or any other operation that we think is needed. As you could see, we had 2 patients who lost a leg, and that is a very small number, but I would say every 5 to 10 years we have a patient who has so much problem, so much malformation, that we decided it is actually better to have an amputation and go on, have a prosthetic leg and forget all the problem that he or she had. And many of these patients do actually very well, very well. So I just show you 2 patients because quite interesting and obviously good outcome. I didn't show you that. 35-year-old male patient who had very active patient, maybe he's even here, I don't know. Swelling, painful varicose veins of the left leg. He had epiphysiodesis at age 4, had multiple deep vein thrombosis, pulmonary embolism. He was anticoagulated. He had a larger leg, prominent varicositis, skin pigmentation, capillary malformation, very symptomatic, couldn't function without stockings. This shows the lateral vein that this patient had. It's a lateral embryonic vein. We measured 3 centimeters in size at one point, depending on whether the patient was hiding it out. But it was about the size of this patient's inferior vena cava. And then up higher, actually, this vein was like one of the variations on the drawing that Patricia had, that actually joined the femoral vein next to the present deep system. So in this patient, we thought, we obviously considered embolization, considered endovenous therapy, but we thought that the sheer size of this vein it makes it a better candidate for open surgical treatment, and actually that's what we did. This just shows you again the final venogram of this patient, and we just took and systematically, using a tourniquet, removed this huge vein all the way up from multiple incisions, and ligated all the side veins on this patient, and then just shows you the large valvulus structure that we removed. It showed the closure. And this operation we did 2 years ago. The patient just came back a couple of weeks ago, had a couple of stereotherapy by Dr. Bjarnason here, and he's been the happiest person on earth and had a very nice clinical outcome of the operation. This was one patient. This is another patient that I just show you for a reason to tell you that why it is so challenging to decide which is the best procedure to do. And I don't know whether surgery is the best procedure. She finished up with surgery, but before she had surgery, she had radio frequency or laser treatment, and she had embolization. And again, it may very well be that, as Dr. Omar said, that these patients, if they need treatment, the best is to treat them early when they have small veins, because sometimes what can happen, this patient was treated with embolization, and the embolization was actually done, let me just point out, right here, you can see the embolic occlusion of the vein here. Now, these veins have pretty strong flow, even though not arteriovenous flow, but a pretty high flow, and the veins can change size. So I'm sure that Ahmad, you know why this patient had the problem, in spite of the embolization and the endovenous treatment. When the patient went back to where he was treated, the vein was completely open. The embolic material was gone, and we found all the wires in the contralateral right internal iliac vein. Fortunately, it was very firmly embedded, and it didn't cause any problem. And then so ultimately, that's what we did. We actually tied off the vein right where from a very tiny incision, treated the upper branch with radio frequency, and treated the lower one with small phlebectomies. So it just tells you that, again, just because somebody does embolization, that it's not exactly the same as somebody does it for this type of a problem. This just again shows the finding. And finally, just one case, because we see patients who come with left lower extremity pain and swelling, and when we do a full evaluation, we find that this patient indeed has a compression of the pelvic vein, iliac vein, what we call May-Turner syndrome, and we have a interventional technique, stenting, where we can really open up these iliac veins now with a large number of patients. And Dr. Omar, your comment today or tomorrow whether they see it in patients or not, but we had a patient who was very symptomatic. The patient had compression of the left common iliac vein in addition to the lower extremity problems, and actually it was very obvious on the venogram too, when we did the IVUS intravascular ultrasound, and then ultimately stented it, and the patient had a very good result. One problem that we have discovered with the stents are now widespread. They are used all over, and they are very good and very effective in the iliac veins. And we are more and more aggressive and put it in younger patients too. One thing that we don't know exactly what happens to the stent if it extends too much into the inferior vena cava. And that is one thing that we have become a little bit cautious, because we have seen that in patients where the stent is pushed into the vena cava, these stents with time develop a pseudointima, and there is a risk that the contralateral iliac vein occludes. And again, we are more and more courageous to put it into younger patients too. The teaching is that they have to push it very much, or at least halfway into the inferior vena cava, to really have a good treatment of the area of compression where the right common iliac artery compresses the left common iliac vein. And when we looked at it in one patient with ultrasound, we actually had to remove the stent because of pain. We found that there was actually a thick pseudo-intimal coverage in this patient that completely occluded the contralateral iliac vein inflow, and we had to actually cut out this membrane that formed over the contralateral side to open up the iliac vein. So it's just, with time we learn when to use these procedures, which otherwise are very effective, but we don't always know the late outcome yet because some of them are quite new. So just from this patient, what I learned is that, first this patient had a lot of pain because they put in a very big stent, and I think we have to be careful with that. And then the other one is that we just have to be careful not to place it too much into the inferior vena cava because it can cause problems. So there is now a lot of several clinical trials, a few venous stents going on to find the right stent for this procedure. Coming back to and finish it up, we just published the 50 patients, and we have done about another maybe 35 patients since that time. All of them had Klippel-Trenaunay syndrome. You see that the complication rate was relatively low, but we had one patient with pulmonary embolism and two with deep vein thrombosis. This shows you the clinical benefit using a scoring system that surgery resulted in. 70% at 5 years of our patients did not need a secondary intervention, and the freedom from pain recurrence at 5 years was 59 years. This is the paper that we just published a couple of months ago, 5-year results of the surgical patients, freedom from severe pain, 59%, freedom from brain intervention, 74%. We also looked at the more recent 26 patients, the utility of radiofrequency and laser, and there is, but we are quite selective in that. So you can consult consensus documents, and we have now 3 upgrades of this IUP document. You can, as Dr. Alomar mentioned, they have a wonderful practice guideline on your website. That's where I found this tool. That's going to, you see, you are becoming a reference source for me. And you can consult that. I'm just telling you my current top 10, all right? Okay. For surgical and interventional treatment. So, number 10, study the anatomy and venous function carefully. And that's why before we do anything, we really want to know fully what's going on. Be sure that there is, number 9, be sure there's adequate deep venous drainage. Number 8, consider removable IVC filter in patients who have major surgery because of a large vein and who had a history of thrombophlebitis or deep vein thrombosis. We would place a removable filter if it's placeable, but you've seen that we are careful because sometimes the vena cava is too big. I would say respect the cases with significant deep compartment involvement, because what you see and feel that may be just the tip of the iceberg. Use DVT prophylaxis around surgery. Number 5, use endovenous terminal ablation, bone and coil embolization selectively. I would even add by real experts. Number 4, for open surgery, use tourniquet, and that's practically to your surgeon, to minimize blood loss and the need for blood transfusion. Number 3, use ligation of the incompetent embryonic vein, perforators, small stab wounds, and stage removal of the veins with small incision. Consider hybrid procedures. And number 2, I would say stay conservative unless your name is Dr. Alomar. And rule number 1, stay conservative.